Welcome back to the Mysteria podcast. I'm Marcus De Silva. This is episode 19, and I'm very pleased to welcome my guest today, Dr. Julio Montaner. Thank you so much for being here. Pleasure to meet you.
Thank you, Marcus. My pleasure.
And it's going to be a bit shorter. We're looking between an hour to an hour 15 podcast. So I just want to jump right in and we'll get the conversation going. So first of all, just tell us a little bit about yourself, who you are, where you're from.
Well, my name is Julio Montaner, as you indicated in the introduction. I'm originally from Buenos Aires, Argentina. I did my medicine studies in Buenos Aires at the University of Buenos Aires. And having completed my early training in Argentina, I was looking for an opportunity to sort of validate my credentials and expand my experience abroad. Part of the motivation was that my dad was at the time dean of the medical school, chairman of various departments and other important positions. So I always had this deep necessity to reassure myself that I was appropriately qualified, both subjectively and objectively, so that one day I could work with my dad, who I loved and admired quite a lot, and hopefully have my credentials be indisputable, so that that was not an issue. As it happened, and largely because of my dad's encouragement, I spent the summer traveling this particular year. I was in Europe. I met a number of people. I was very excited about the possibility of going to work as a trainee, as a postdoctoral fellow in either in England, France, etc. And nothing happened. I got a very nice reception, but no job. So subsequent to that, my dad suggested that I accompany him to an international meeting that was taking place in Uruguay, next door to Argentina. And I did so. My dad didn't stay around for the meeting. He just did his thing and he moved on. I stayed for the 3 days of the meeting. And lo and behold, I walk into this conference room to attend the lecture on the subject that I was very interested on, that I always found fascinating but very complicated. And there is this guy presenting in a language that I didn't quite master at the time. My children would argue that I still don't master, but that's okay. And I sit at the audience and start listening to this guy presenting. And it was really a revelation to me how I could understand everything perfectly well, even though he was talking about, complex issues in a language that was not fully familiar to me. And I just had the realization at the moment that the reason why this topic was so easy to understand when he was actually explaining it, in contrast to when I tried to learn it from my professors back at home, it was because he actually understood what he was talking about, as opposed to be repeating something that he had read or been told or whatever. And that was a huge thing for me at the moment. I became very motivated by his presentation, and I actually started to think about different ways of doing things, etc. Much of what he was talking about were physiological research experiments in animals, looking at the pulmonary function, which was the area of my interest at the time. So at the end of the meeting, I decided I was going to approach him, but there was a funny twist. There was a second person speaking at this meeting. He was from down south in the United States. In those days, it was still fairly prevalent. He was smoking his pipe, and he had a Nashville accent on top of that. So I didn't understand anything he was talking about. let alone the substance. I didn't understand the English. So when I went to approach these guys, they were having a coffee at one of the booths, and I was very strategic, and I approached him from the side, the other side, so that the professor I was interested on could not engage with his colleague. And the guy was extremely kind. He engaged with me. He apologized to his friend. He invited me to sit down and share a coffee with him. I started asking questions. He received all of that very well. In fact, by the end of the conversation, he said, you know, Dr. Montaner, those are very interesting questions. And I wonder if you wouldn't like to come and do those experiments in my laboratory. To which I promptly responded, oh, no, thank you so much, Dr. Hogg. His name was Jim Hogg. I said, no, I'm just asking because I'm interested, I'm curious, but you know, I want to do clinical research. I'm not interested in basic animal research. And he looked at me seriously and he said, you know, Montaner, I'm going to give you a piece of advice. The best clinicians I know, the most successful academicians, they all spend time learning fundamental physiology. And that was the key to the success, because whether you believe it or not, it gives you an insight into human physiology that is actually something you can build on no matter what you're going to do later on. And I look at the guy and I said, well, thank you so much. And he said, well, look, don't, you know, here, this is my name, this is my address. Think about it. If you change your mind, let me know. And so be it. I said, okay, well, thank you. Very nice meeting you, whatever. You have to imagine, I was about 24 years old at the time. Jim Hogg was a professor of pathology at UBC and at St. Paul's in Vancouver. I don't mind confessing, I didn't know where Vancouver was at the time either. So it was like all news to me. I left the meeting. My father was no longer in Uruguay at the time. And so I ran into his sort of second in command. And I tell the guy, this is what happened to me. And I tell the story. I show him the thing I got from the name of the guy. I said, do you know who this is? They said, no, I have no idea. I said, this is Professor James Hogg. I mean, this is the guy. And he started giving me his CV or whatever. I said, Julio, this is huge. I said, well, you know, but I'm not interested. I said, no, you don't understand. So he grabbed me. He took me to meet what I would characterize my father's sort of competitor, number one competitor in the field of respiratory medicine in Argentina. And he says, here, you tell him what happened to you. And I tell him, and he says, Julio, listen, you're going from here to Vancouver, and I'm going to let your father know that I sent you there. I thought, this is crazy. So all the cockiness, if you want, disappeared. I got really nervous. I couldn't sleep that night. The next day, I go back to the conference. I meet Professor Hogg, and now quite shy on my part. I said, you know, I hope you don't mind. I didn't offend you, but I've been thinking about it, and I'd like to reconcile. Said, yeah, no problem, absolutely. And lo and behold, he offered me the job. I wrote to him when I came back home, and within months I got an offer. And 1981, I came to Vancouver to do a postdoctoral fellowship in respiratory medicine. And that was sort of transformational. I was really committed to doing a year or two maybe of training, but I really wanted to go back home and work with my dad, who was a respiratory specialist. And I wanted to hopefully use this experience to build a solid career and be able to do something different when I came home. And it was not to be.
The type of work that you're involved in is quite unique to St. Paul's out that way. And when did that start to take off?
So what happened was that I was happily doing my work. And our research was going well. my first surprise was when 3 months into the job, Dr. Hogg used to invite me often to go for a lunch break, walk around the hospital or the park or whatever, just to chat and catch up and see where things are going. And so 3 months into the job, he says to me, so what's your plan for next year? I said, I got no plans. I said, well, Julio, we need to talk about next year. I said, well, but next year is 9 months away. I mean, come on. I said, no, Julio, that's the way we do things here. We need to plan for the future. I said, well, I don't know. I mean, what do you have in mind? I said, well, I think you're doing very well, and I trust you're happy and you're enjoying what you're doing. I thought you could stay another year. And I said, well, bring it on. You know, I was really enjoying my work, and we were starting to do some interesting stuff. So that was 1981. 1982 came around, not related to the subject matter, but I met Dorothy, who eventually became my wife, and we started a family, but that's a separate matter. But that sort of brought some stability to what I was doing. So came 1982. By that time, it became apparent that there was an epidemic emerging in North America. Eventually became AIDS, eventually became HIV. But in all honesty, we didn't even know in Vancouver, in Canada, that this was a real thing or it was a real threat. You know, these things happen or not and come and go. There was only reported a bunch of cases in various cities in the United States. And the epidemic in Vancouver really didn't hit until 83 or thereabouts. So around that time, my plans continued to be to do respiratory medicine. And so I was having increasing conversation with Jim Hogg about what my future was going to be like. And so one day he said, you know, Julio, if you really want to fulfill your dream of being able to go back home and develop a significant academic career and have a public health impact and so on and so forth, you probably need to complete a full training here. 2 years of research is a good base, but you know, you may want to just join the residency training and do the whole thing all over and just get it over with, and you'll be perfectly qualified. And I look at him and I thought, oh my gosh, this is a bit much. And now you have to remember that meant revalidating my degree and sitting exams that I already had sat. But nonetheless, I thought about it. I talked to my well, eventually Dorothy became my wife. And I said, okay, let's do it. So he took me to the chairman of the Department of Medicine. He put forward a very good work for me. Of course, I had to submit my CV and a bunch of stuff. And John Rudy, the chairman of the Department of Medicine at the time, he offered me a job as a resident at UBC St. Paul's. So I was basically based at St. Paul's. As I was progressing through that, HIV was becoming a significant concern. By 84, the virus had been discovered. Still, the numbers in British Columbia were relatively small by comparison. But I started to become clinically involved. And as I became a respiratory fellow, then by the mid-80s, there was a pneumonia that was characteristic of AIDS, previously unheard of, virtually. It was called pneumocystis pneumonia. And this thing was devastating people infected with HIV. It would really develop into a very serious pneumonia most of the time and eventually kill people right, left, and center. So it was a real driver of the epidemic in the 80s and early 90s. And so I naturally, because I was the youngest member of the team and there were so many people now it was taking off. I was being sent to the emergency room to look after one after the other patients with AIDS-related pneumocystis pneumonia. Eventually, we made a couple of observations. The details are not really no longer relevant, but they were sort of significant and led me to believe that we could try an anti-inflammatory treatment as adjunctive to the antibiotics to try to crush this pneumonia and bring it into some sort of response. So what I came to understand is that people with HIV didn't have so much deficiency of their immune system, but over and beyond that, they had an immune dysfunction whereby their immune system was weakened, but it was at the same time out of balance. And so when the pneumocystis organism affected the lungs, they mounted a disordinate humoral antibody response with a very significant deficit of the cellular immune response. And so they would be drowning on the immune globulins that were actually secreted to affect the organism, the pneumocystis, and they were dying before the antibiotics could actually deal with the pathogen. And so what I did is I started to use anti-immune drugs, anti-inflammatory drugs, in this case, corticosteroids, to suppress the inflammatory response. And in doing so, we bought them time for the antibiotic to respond. And then what it used to be very low rates of survival became very high rates of survival. And that led to a paper that eventually began to turn the tide in terms of managing people with HIV who had this particular pneumonia. As I was doing more of this work, the Americans in particular, the group in San Francisco, wrote a very complimentary editorial in a very significant sort of scientific journal about Dr. Montaner's work. In fact, if I tell you the truth, it was before I actually submitted my paper for publication. So much so that when the paper was actually submitted, it was rejected at the same time that the editorial came out in the competing journal. So I was devastated. I went to see Jim Hogg, who was still my mentor, and I asked him for advice. He said, Julio, you know what? Just call the editor. Tell him that I said you should call him. This was a big thing. Here I am calling the editor on behalf of Dr. Jim Hogg to tell the editor that actually he had made a mistake. And lo and behold, the editor said, yeah, Julio, you're right, we made a mistake. And so he went on, he published the paper, and that became a very widely cited paper. I started to get invitations for international conference and the like, at a time in which I was still I was a chief resident at St. Paul's. So this was around 86 now. By that time, the first anti-HIV drug became available. That was ACT. It was a specific drug to affect the virus. And through the work that I had done, even though infectious diseases was not my thing, I had come to realize that it didn't matter that we were able to fix the complication, infectious complication that patients with HIV were going through. At the end of the day, the underlying immune defect related to the viral replication was going to be always the end game, because it would lead to more complications and opportunistic infections and cancers and so on and so forth. So I decided to get involved in that trial with John Rudy, who was the principal investigator for the first ACT trial in Canada. He gave me an opportunity to do that. And to be honest with you, by 1987, when I finished my training, by this time I was married and I had changed my mind, partly because of my wife. And I decided, under some pressure, to stay in Canada, which I don't regret one bit. I had a conversation with John Rudy. He was keen to develop a further expertise in HIV in the hospital here. And I always remember him coming to my office that particular Friday. And he arrives and he says, Julio, I have a problem. I need help with my HIV problem. The details don't matter, but he says, I don't know what to do about it. And I said, well, John, I mean, you know, quite obviously what you need is somebody young and with an academic focus who wants to build a program and, you know, somebody like me, but who's interested in HIV. He looked at me and he said, will you do it? I said, no, I want to go back to respiratory. And he says, if you do it for a year, I'll get you your position in respiratory after that. I said, okay, you got a deal. And that was in 1986. I basically came onto faculty in 87, and I never went back to ask for my respiratory appointment. I remember vividly people saying, you know, are you sure what you're doing? You know, this thing could be over before you know it. And I always rely on the tuberculosis framework. My dad was a TB specialist within respiratory medicine in particular. And he used to tell me many stories, but the one that resonated with me was when he used to say, look, Julio, in 1956, the year you were born, I had access to streptomycin. It was an experimental drug. It was given to me, and we tried in a bunch of people who we thought they were about to die, and it was a miracle drug. It worked for a time, and then patients developed resistance, and it didn't work anymore. But building on the success of streptomycin and combining with other drugs, we were able to overcome that phenomenon, and eventually we came up with a cure. So by the mid to late 50s, we actually had a cure, and yet we have not been able to resolve TB globally because it takes more than a cure to solve an epidemic. And so, you know, even very early on, all of these resonated with me. Lo and behold, I became a champion of combination antiretroviral therapy, much a la TB, using the same formula. And ultimately, by 1996, within a decade, we had our own data that showed that triple drug combination therapy could actually shut down viral replication, allow for immune recovery, and in doing so, stop people from dying from age-related causes. That became the theme of the 1996 conference, which, as it happens, we were organizing in Vancouver. It was a large international conference, which went down in history as the birth of highly active antiretroviral therapy. We call it also HART. And I have to tell you, my mom and dad came to the Vancouver conference in 1996, and it was a tremendous opportunity and a great deal of joy for me to be able to share the success of our work with my dad, and then take some time off with him and my mom and my family up the Sunshine Coast. And the truth is that by the time we came back from that holiday, they went back home, the impact of our new treatment, which was embraced by the province of British Columbia, even before we announced the results at the conference, were already palpable in our clinic. Mortality from AIDS started declining immediately in the second half of 1996, and it has been declining ever since.
Yeah, there's a couple of things in there I just wanted to touch on. First of all, I think it's really funny that there was a good job at dangling the carrot to get you to take part in that program. I actually was quite impressed with that. That was pretty funny. It's quite smart. Yeah, so I just thought that was kind of a funny thing there. But so at that time, so heading into, I guess we'll say, maybe we'll say right around 1996 there. Like, because you even mentioned that people were saying to you, like, are you sure you want to take that position? Like, it might be over soon. Obviously, you know, now we're at 2021, you know, that proved to be not true. So I guess just kind of related to that was what were some of the social and cultural attitudes towards, now at that time in 96, was it then known as HIV or was it still known only as AIDS?
Yeah, HIV was discovered in 1984. And so we knew there was a virus in 1984, and that's what opened the door for the treatment. As for the societal sort of attitudes towards HIV and AIDS, I mean, it's been talked about a lot, and I could go forever, but it was challenging, challenging to say the least. You know, people today may not remember what it was like back then, but all of the most affected populations, including homosexual men at the time, were very seriously disenfranchised around the world. The fact that the epidemic was so predominant in the south of the world, the sub-Saharan Africa, and so on and so forth, it brought with it a whole bunch of other social, political connotations. It was a huge learning experience for us because, as you probably appreciate, myself and many others, we came at it from a biomedical perspective, and we were very poorly prepared in terms of our educational background and the like to deal with all of the multiple other layers that HIV brought with it. There was also a tremendous mistrust on the part of the community, the most affected communities, for any efforts that were undertaken, from not trusting industry to not trusting academicians or researchers. And so, you know, we had to prove ourselves. And whether it was ACT UP in North America or a number of other organizations, they were very upset, rightly so, about the fact that profit was ahead of saving lives. And, you know, in all honesty, this is a theme that still continues today, although we have made tremendous progress, particularly in our mess. But it's still something that is incredibly prevalent. People think, oh, well, all of this is over. Well, it's not. If all of that would have been resolved, we would be in a very different place when it comes to the epidemic today, and we're not. And we can talk about more of that as we move forward. But it was a challenge. In fact, when in 1996, we first presented our data, there were two clinical trials, one that I led, the INCAS trial, and the other one, the Merck 035 trial, that was led by a colleague of mine, Trip Gulick from New York. When both of those came together in 1996, and eventually were presented together with a bunch of other data at the Vancouver conference, as well as the new proposal for highly active antiretroviral therapy, which we sort of came up with a very prestigious group of colleagues that came under the International Society USA banner kind of thing to develop those guidelines. When we put all of that together, we became a target. ACT UP sabotaged the meeting. They accused us of trying to kill them with ACT, which by then was regarded as a poison. And so it took a lot to overcome that kind of situation. But you know, we had the science on our side, and we eventually were able to show that we were on the right track. Granted, there were a lot of challenges when it comes to the practicalities and the feasibility of the strategy that we first unveiled in 1996. And yes, it was not perfect, and it needed to be optimized. But you know, but we did the homework, and within the next decade, we were able to get rid of a bunch of the more toxic drugs that were part of those regimens and replace them with others that had a better safety profile. And eventually, treatment became a reality, not only for the North, but also for the South. In fact, my colleague, Dr. Mark Weinberg, who passed away a few years back, Mark from Montreal, who became the president of the International Society shortly after the Vancouver conference, made it a sort of a focus of his work as the president of the International Society to advocate for treatment to come to the south of the world. Those were the Mbeki days and so on and so forth, another nightmare. But he really put a tremendous amount of effort, as he did the IAS and a number of others, to ensure that this came to be. And eventually we took the conference to Durban back in the day to really open the door to promote treatment in sub-Saharan Africa, which at the time was unheard of. It was not even a proposition. So yeah, lots of challenges. If you allow me, I'll tell you an anecdote that I'll tell you two anecdotes that are very close to my heart. The first one was when we were doing the early work on ACT, and the British came out with data arguing that ACT was not only didn't work, but it was toxic. And it made it into the news, CBC News. In those days, I used to wake up with a radio clock, and it was I think it was the early edition, but it was something like that. And the early edition comes up, and you know, I wake up with the early edition. First article or first issue that they're covering, data from the UK shows that ACT doesn't work. And my daughter, Michaela, my eldest daughter, who would have been 4 years old at the time or something like that, runs into the room, jumps on me and said, Daddy, ACT doesn't work. What are we going to do? I said, don't worry, honey. Don't worry. They're confused. We got data that shows that it actually works. It's going to be okay. So that's to show you the degree of the penetration that all of these ongoing challenge and confusion and you know, if you think COVID is challenging, well, HIV was very challenging. And the other anecdote that I often refer to is that when my children went to school, they would come home and they always tell me the story. They were asked, what does your father do? And they would say, well, he's an HIV and AIDS researcher. And they asked why. I don't remember ever my father being asked why. He was a respiratory physician. I don't remember ever him being asked why he was interested in tuberculosis. There is no why. Why is my friend a cardiologist, a rheumatologist? No, but HIV/AIDS, why? What's wrong with your father? You know, and these are the kind of subtle things that we were, I mean, those are the subtle ones. I don't want to go to the not so subtle, but this is something that persisted. I had very senior people in my own institution, and I won't name names, and I won't tell you who, and I don't tell you when or how or where, with tears in their eyes, telling me, I wish you were a cardiologist. So much that institutionally we like to celebrate the success of our program and so on and so forth. I tell you, the ambivalence about the work that we do still today, it haunts us, and it's a very challenging thing. So it is what it is. We're making the best out of it, and we continue to fight the fight, and we're quite proud of it. But I never thought that I would have the Prime Minister of my country now being Canada, being my #1 enemy back in the day. And he was. I never thought that I would have the Minister of Health at the 1990 conference. I beg to differ. At the 2006 conference in Toronto, where I was a keynote speaker. And for the first time, I presented our own new proposal that revolutionized the global management, care, and control of HIV/AIDS, the treatment and prevention strategy, which we can discuss in detail if you want, to tell me to my face, you know, Julio, you guys are the problem. And I look at him and I said, Minister, I don't know what you're talking about. I said, yes, because the work that you do promotes the conducts that promote the spread of HIV. That was the federal minister of health of this country. So when I said at the time that I was ashamed of who were leading this country, I wasn't meaning to be un-Canadian. I meant they were un-Canadian. And I still insist today that kind of attitude is actually maybe less public today, but it's still very pervasive and very persistent. Anyways.
Well, you brought up a really great issue, because that just highlights the fact that when you politicize medical issues or things of that nature, the detriment that it can cause. I mean, that's pretty incredible that he actually had the guts to come up to your face and say that. Like, yeah, wow.
And this was at an award ceremony where I was being celebrated, and he was supposed to be celebrating me. I mean, and I won't name the name, but you guys can go and figure out what I'm talking about. I mean, it was not pretty. And so, again, so I'm just going back to the treatment prevention story. As I was telling you, 1996 comes around, we come up with a treatment that it works. And, you know, we could have said, bingo, we'll sit on our laurels and just ride this wave, and that would be great. But, you know, the unique feature of the program in British Columbia is not only that we purchase, distribute, and supervise the treatment for everybody infected with HIV in the province, but actually we monitor it exhaustively so that we can actually identify what's working, what's not working, what needs to be tweaked, and so on and so forth. And so by the year 2000, by 1989 actually, I started to see something that it was counterintuitive. People, and don't get me wrong, I mean, people still could die from HIV/AIDS, but the rates of death were plummeting among people who were engaged in treatment. So what that means is that the denominator of the number of people living with HIV in the province of British Columbia was actually growing. Yet the number of new infections started to plateau and decline. And so we asked the question, could it be that treatment is interfering with HIV transmission? Because at the time, that was felt not to be possible. And I explained that. What happens is that these treatments are what we call virus static. They are not virucidal. So virus static means that they stop the ability of the virus to reproduce. But the virus, the genomic material of the virus, lives within your cells. So it was well recognized that if the cell is infected with HIV and you're taking treatment, basically the system is protected because the virus cannot reproduce. But if you interrupt the treatment or you don't take it properly, then the drug pressure that we call it disappears, and the virus wakes up and it comes back right away. So if you can imagine a situation where I'm now infected with HIV and I have a partner, my partner is not taking treatment. The argument at the time went, if Julio is taking treatment and the virus is suppressed, he's doing fine. But if now he gives a kidney transplant to the partner or an injection with his blood to the partner or has sex with the partner, then because the partner is not taking treatment, the virus will explode and that person gets infected. In fact, there were cases of, say, kidney transplant related transmission, so on and so forth. So there were reasons to be concerned. And so what we did is we looked at the baseline syphilis transmission in the province, and we said, well, let's see what happens, because if there are more people living with HIV, there are less new infections, and there is more syphilis going around, particularly in the gay community in BC, guess what? Safer sex is not the answer. at least not the answer to the reason why we're seeing the cases going down. And so we started to look into various data sets. We looked into the data sets in the downtown east side, where we had a cohort of injection drug users that was very well characterized. Then we looked into the international cohorts, working together with UNAIDS, the United Nations AIDS program. And anywhere we looked, we were able to show that the number of people that were on treatment were effectively being subtracted from the denominator pool, namely the number of people that could be donors of HIV, if you want to put it that way. And so we published that in the Lancet in 2006. It became a plenary at the International AIDS Conference in Toronto. And that's when I had this exchange with the minister, who did not believe that this was a solution whatsoever. Nonetheless, I was very fortunate that at that conference, I was able to introduce this topic to Stephen Lewis, who became a huge supporter and champion of the cause. And shortly thereafter, also at the conference, I was asked by Vancouverite, actually, Alison Lawton, to come and meet a friend of hers. Lo and behold, it was President Clinton. So here I am telling President Clinton everything about it. And the president says to me, Julio, we will support you. The funny thing was that at that time, I could get no support from public health. I could get no support from the scientific community. I could get no support from the community, from the medical community, from anybody. But I had Stephen Lewis and President Clinton. And with their support and the IAS, International AIDS Society, who eventually I became president of, on this sort of platform, I was able to take this to the rest of the world, eventually secure the support of United Nations AIDS program, when Michelle Sidibe became the executive director. And this became my obsession, my focus, and what I needed to do. At the same time, I was fortunate that a good friend of us, Terry Salmon, a former chair of the St. Paul Foundation, agreed to introduce me to the premier at the time, Gordon Campbell. And although I had to squeeze into his office under a false pretense and upset a whole bunch of people, within 15 minutes of being in his office, he grabbed my materials and he says, Julio, with your brains and my money, we're going to make this happen. And, you know, he was a man of action. He immediately summoned his Minister of Health, Mr. Falcon at the time. And with him, we agreed to set up a plan to implement treatment prevention, which at the time was regarded experimental in any other jurisdiction around the world. And BC was actually the first place that implemented it. And in all honesty, it wasn't all that difficult to do the math. All I was asking is, let's make treatment available to as many people as we know they are infected, so that they can have the best possible clinical outcome. And secondarily, not only prevent death and AIDS, but actually prevent HIV transmission, because we were convinced that treatment would render people virtually non-infectious. And it took a good decade, but by 2015, we managed to get scientific consensus. In fact, we brought the International AIDS Conference back to Vancouver. I had the pleasure of chairing that final conference, final in the terms of the story, where the United Nations, WHO, the Vatican, and everybody else came together through our personal lobbying and involvement to say, yes, treatment as prevention is the way to go. It became part of the United Nations Sustainable Development Goals agenda. We took it to the African Union, and every single country endorsed the proposal. We actually crafted a new goal, basically saying that if by 2020 we were to achieve at least 90% of the people diagnosed, at least 90% of those on antiretroviral therapy, and at least 90% of them virologically suppressed, by 2030, we would see a 90% decrease on death and a 90% decrease in new infections in every jurisdiction that apply these. Now, you may want to ask me, have we succeeded? And the answer is yes, in British Columbia. What about the rest of the world? That's a problem. Unfortunately, if I were to be 100% candid with you, I had to say we have fallen behind badly. Why? Because of the lack of political will. And why? Well, because AIDS fell off the agenda. There is no longer the political focus, the public attention on AIDS as once upon a time. And so when I went to the United Nations, the government of the time, which will remain unnamed, they said to me, and I had this telephone conversation with the Foreign Affairs Ministry, Dr. Montaner, thank you for the invitation, but we're going to decline. However, you are welcome to go, and we are not going to object, as if. And so I went to the United Nations by myself with a few of my colleagues, but Canada was not there. In that interim, I was in the White House 3 times advising the Obama administration, but I was not welcome in Ottawa. So that tells you we have a problem. In 2008, which would have been just after we announced treatment as prevention and the whole conversation was beginning to become significant, when the economic recession hit, it became very convenient for governments around the world to say, sorry, we can't invest anymore. And so if you look at global investment on HIV/AIDS, particularly for low and middle income countries, it plateaus in 2008 and it never recovered. And the mantra became, we need to do more with less. I mean, there is only a limit that you know, how far you can stretch your resources. And so when we fail to deliver on the 90-90-90 target by 2020 at a global level, don't look at me and say, Julio, you failed. No, we didn't fail. No, the political leadership of this world failed. And they're still failing, despite the fact that many like to pretend that they are doing a good job. They are not.
It's quite surprising, particularly when you discuss the fact that Clinton was, at the time, President Clinton was had your full support. Because generally speaking, at least if you're just talking about Canada and our neighbors down south, on most issues, they tend to be more conservative leaning. You know, even a liberal, an American liberal versus a Canadian liberal, we tend to go a little further to the left, just, you know, cultural, social, you know, that's just the way it is. So it's just very surprising to hear that not only was the Canadian government not supporting you, they're actually against you, and that you had so much support from President Clinton.
Well, you know, to the credit of the current federal administration, Justin Trudeau was in my office during the campaign at the time in which he was third on the polls. My colleagues made fun of me that I even wasted my time meeting with him. And I said, look, I meet with everybody all the time. I just need everybody's help to make this happen. And we had a great meeting. Hedy Fry was the one that facilitated it, and I'm grateful to her support because she's been terrific. And so within weeks of having been in my office, he wrote me a letter, which I have a copy sitting here on my window. And he said, dear Dr. Montaner, if we were to form government, we will commit to endorse the 90-90-90 and we'll act accordingly, blah, blah, blah. Well, I thought it was great. My colleagues were still making fun of me, saying, yeah, sure. Lo and behold, he won the election. He appointed Jane Philpott as his Minister of Health. I never had the pleasure of meeting Jane Philpott before she was the minister. On December 1st, a month into her administration, she actually endorsed the 90-90-90 before I even met her or even asked her to endorse it. which I was extremely grateful for. We did a lot of good work with Minister Philpott back in the day, and I am again grateful for her support. But the reality is that in Canada, health is a provincial jurisdiction, and it doesn't matter what the federal government wants or says. If the provinces don't want to do it, it's not going to happen. And I'm not going to point fingers across the country, but I can tell you that British Columbia has brought AIDS under remarkable control. We have reduced morbidity, mortality for greater than 95%, new infections for close to 90%. And our epidemic today is actually contracting significantly. Why? Because people, their average age is my age. And so the top end of the cohort is dying of old age. And that's what we were hoping for when we started this work 30, 40 years ago. And so this is happening. And yet the many jurisdictions across the country, they rather make other things their priority without realizing, and we have shown this in excruciating detail, that treatment as prevention prevents morbidity, prevents mortality, prevents new infections, and saves money. In fact, every dollar that you invest today has a huge return on the investment, to the point that within a decade, you are saving money. You know why? Because people don't get sick, so you get to close the age ward, as we did here about a decade ago. You can actually contract the clinics and redeploy the resources to do other things. All of that because treatment as prevention, it really deals with it. Now, do we need a cure? Do we need a vaccine? Of course, that would be great. I mean, we could never eradicate HIV, as make it go away completely, until we have all of the tools. But today, we have transformed an epidemic concern in British Columbia into an endemic concern, which means it's a sporadic event that, you know, may happen like here and there, an accident or whatever, but it's incredibly gratifying.
In my last year of law school, I took, in each semester, I took a medical law class, medical law 1, medical law 2. And I believe it was in medical law 1 on the final exam, actually, which was good. I actually prepared for that one appropriately. But the essay question was, well, actually, let me back up. So in the tutorials and the lectures from the corresponding week, there was a whole lecture on treatment versus cure. And at the time, we were looking more at obesity, just because in the UK, it's a costly, it just costs the government a lot of money. And the UK health system is very similar to that of Canada, that's public and et cetera. And one of in the tutorials when we were discussing it, we did discuss a little bit about HIV, just because treatment as prevention versus cure, it's relevant in that sense. But what was so interesting was that so obesity and heart disease were the two that I remember specifically. And the data from basically just saying, like, how do you really cure obesity? Well, you can't really cure it, but you can implement measures that will lower the rates of it. And the money that you will save is huge. Like, and that was pretty much undisputed in every article and every research paper that we saw. And the same effect was with heart disease. And on the final, I actually referenced HIV because luckily I had a lengthy discussion with my dad to study for that exam. So that was quite helpful. But bringing it back to you, was that a hurdle when you're talking about the 90-90-90 program or implemented plan? It conceptualizing that rather than looking for a quote unquote cure, this is actually the most effective way, because it just seems so obvious. Like, that's the thing when you look at the data, but, you know, convincing people seems to be a bit troublesome at times.
You know, I think there were many layers in terms of objections to the implementation of a program like 90-90-90. From the practicality of it, oh no, it cannot be done, to the fact that, Julio, you're out of your mind. I mean, you're asking for viral load testing in the south of the world where they don't have access to that technology. And I kept on saying, guys, if we don't set up ambitious goals, if we don't set up a viral load testing goal as a parameter, then viral load will never go to South Africa. So it's a chicken and egg phenomenon. And so I managed to convince my colleagues to suspend their animosity for these particular areas and launch the 90-90-90. The same day that we announced the 90-90-90, Roche Laboratories discounted viral load testing by 90% in the south of the world. Just to give you a sense how some of these things can be overcome. The other thing was there is enormous, let alone the people that don't care, the people that refuse to accept it, and all of those are over there. But even within our professional circles, there was a whole large group of people in the public health domain, some of them very highly placed in positions of great power, who would argue that medicalization of public health would actually destroy the effort. And in fact, they rely on faulty assumptions, saying that if you were to adopt a policy that treatment stops transmission and treatment was less than 100% effective, these would be associated perhaps with sexual disinhibition, for example, then the potential partially suppressive effect of treatment on transmission would be significantly overwhelmed by the sexual disinhibition, and the whole thing would be a disaster. To which I would respond, buddy, it's simpler than that. I'm asking to give treatment to the people that need treatment because they need treatment so that they don't get sick and they don't die. And you and me, we have an obligation to ensure that they understand that this is the best for them and they need to take it properly, and that doesn't mean that they can immediately suspend any other precautionary measures. So why are we making such a fuss? It was all ideological. Some in public health, they were still insisting that it would be ABC, abstinence, be faithful, and use condoms, after 30 years of showing that ABC was not working very well. So it's challenging. And all you have to do is look at COVID, and we're doing a lot of the same with worse results, and yet keeping on doing more of the same. And something has to change. And I get it. Yes, there are enough vaccines and whatever. Well, why are we not lifting the patent protection and allowing the vaccines to be done and distributed everywhere? Well, because somebody has to pick up that mantle, and I guess it's not my job, and I have other things to do. But in all honesty, we cannot keep on doing the same thing over and over again and expect different results. So we did it for HIV, and it worked. And my mantra is, if it's not working, we need to disrupt it.
Well, and it just goes to show what ambition and hard work can achieve.
and the scars too.
We're running low on time, but to close the show out, could you just tell us a little bit more just about specifically the clinic at St. Paul's Hospital and the kind of work that you guys do, and just a little more insight into that?
Well, I think that the main principle for us has been, as I outlined earlier, to try to meet our clients where the clients are at. So to illustrate that, in 1996, when the treatment became available, we were delighted. The success of the strategy was obvious, but it created a lot of problems for us. First, the treatment was complex. Multiple pills, multiple doses. Side effects were significant. In addition, earlier on when I referred to this issue, I purposely said, death rates declined precipitously among people engaged in treatment. What I didn't tell you is that they didn't change one bit among people who were not accessing treatment, which means, obviously, that there was a constituency out there that was not quite getting the message, or the message was not getting to the people. And even if the message was getting to them, the access was problematic. So back in the day, we realized that, and this is, I think, where I broke the mold. I was a science-based, medical, academic type of person, but I became more of an implementer somewhere along the line, realizing that there was a huge implementation gap between what we knew and what we actually were doing. It was easy for me, Professor Montaner, stand up at the podium and say, you shall do this and shall do that. And when you do all of this, everything is going to be fine. And then I came back the next year and the year after and every year thereafter, and nothing changed. And the reality is that sooner or later, you had to come down from the podium and, get your feet and hands dirty by going to the front line and understanding who is in trouble, why are they in trouble, and where do you meet people in an environment that is safe and accessible to them, not to you. Now, I don't claim to be Mother Teresa myself, but working together with our colleagues here at St. Paul's and a number of others, we develop programs, whether it's at the downtown East Side or up in Prince George or wherever we needed to go, to try to meet the needs of the various groups that we were trying to help. And, some of this is challenging because it's easy for a consumer to say, I need a program that looks like this. And you know what? I run the provincial program and I have this amount of money to, make it work. So I need to be creative. How am I going to make the gender specific and socioeconomical specific and district specific and blah, blah, blah programs that are going to meet your needs? Obviously, we made progress. Obviously, we don't run on a Maserati. We run on a VW or whatever, and it's working very well. So you don't need to go at the extreme. But what we've been able to do here at St. Paul's, but more importantly, throughout the province, from the headquarters that we have here at St. Paul's, is to promote the development of both culturally, socially, economically sensitive programs that fit the needs of various people. So that's the reason why we became involved in supervised injections, safer drug supply, gender-specific programs, and so on and so forth. Why? Because we needed to do that. 4 or 5 years ago, PrEP became an issue. PrEP is pre-exposure prophylaxis. So what happens is this: triple drug therapies were the mantra for treatment. New data emerged that showed that you can combine 2 drugs in 1 pill, and if you take it daily, sometimes less than daily, but it doesn't matter. But if you take it regularly, if you are exposed to HIV, it prevents acquisition of HIV. And believe it or not, it was a huge effort to get the authorities at the time to sign on to it. Why? Well, because quite frankly, this was a luxury item. There was felt to be, why are we going to do this for your patients when we don't do it for anybody else? I said, well, very simple, because we want to end the AIDS epidemic. And I want to be the one to do it. And besides, it saves you money. And so eventually, Minister Dex came into power and he signed up for it immediately. He was very supportive. And guess what? Over and above treatment and prevention, with implementation of provincially funded PrEP for people at risk, I'm talking about men who have men predominantly, who were at the higher end of the risk spectrum, we have been able to decrease over 2 years, 30% new infections over and above treatment and prevention, which means that we need to be strategic, but also we need to be open-minded on how we approach the specific populations that need our help. And if you approach it with biases that necessarily exclude some or others, then you're not going to solve the problem.
Yeah, I know it's funny. I'm sitting here, I'm like, oh, I'm just enjoying myself so much. But it's funny because one of the things I was talking about with my family and a few friends was that when you're any discussion on HIV or AIDS for someone my age at 24 is really not something that we know a lot about. Well, we don't know a lot about a lot of stuff, but particularly that. And that's why I think it's so important, because how you pointed out earlier, the fact that it's as an issue, it's not sexy anymore. There's so many other issues, those hot button issues that get the attention. And unfortunately, when you think about it from a political perspective, the things that get attention get money, or get spending. And that's, it is what it is.
It's fair to say that your generation, much like my children's generation, my children are in their 30s, they grew up in the post-AIDS era, despite the fact that there is no such a thing as the post-AIDS era. But we in the 80s and 90s, with the success of the treatment, in a way, some would argue we became our worst enemy. Well, I'm not going to apologize for it. All I'm going to say is that we need to reactivate public interest, public understanding of the significance of this, what continues to be a global pandemic, so that we realize that this is a pending assignment. It is not done. It's not a done deal. We have the tools, and just to be clear, the treatment of HIV in the south of the world today can be make a reality for somewhere between 50 cents to $1 a day. So you can't tell me that that's not doable. Yeah, you can subsidize it more or less or whatever, but when you have millions of people in the south of the world living with HIV/AIDS, this should not be a matter of debate. It should be a matter of just let's do it and get it over with.
Well, thank you so much for being here. It was kind of funny. I can't believe how fast it went by. It was the most interesting and fastest hour and a bit of my life that I went through. But it was an absolute pleasure having you on here, and I certainly learned a lot. And it's definitely going to be one that I'm going to be tuning into a few times to go over it again and again. But thank you again for being here, and hopefully in the future it'd be nice to do one in person instead of on Zoom. But you got to do what you got to do.
The time will come.
That's right. Thank you so much.
Thanks.